Lovely warm welcome. Thanks for attending this session. I'm Rich Sanders. I'm a geospatial consultant with NHS South Central and West, and I'll see if my slides work. Yeah, here we go, supporting the measles outbreak using geospatial. Wrong button. Here we go. Okay, so all this work sprang from our relationship with NHS England's public health team. We've been working on some cancer screening apps. I've got to press two buttons at once. This is confusing. We've been developing apps that could show you the rate of cancer screening for multiple programs. So cervical screening, bowel screening, breast screening at GP practice level. Cancer screening is important stuff. I probably don't need to tell you guys that. Pick up a cancer early with a screening program and outcomes are much more positive. Outcomes are linked with deprivation and social determinants of health. Sadly, some people in some situations are far less likely to have cancers picked up early, and the public health teams are working hard to change this. So the graph up there shows eligible population in orange with screened populations in green for each of the 7 ICBs, integrated care boards in the southwest. Each of the GP practices are coloured with a RAG rating showing whether the rates are okay. That's the green. Are there any green ones? There's some green ones. Yep. Okay in amber or red really needs some attention. But the Southwest wanted this time to talk to me about measles. I initially thought, childhood illness, but no, it's a serious and most infectious disease spread by respiratory route. Yep, that's right, the most infectious, not COVID or anything. It can be mild, but it can cause severe complications, such as pneumonia and encephalitis and even death. I looked up some numbers about it. In 1980, 2.6 million people died from measles worldwide. There's a safe and effective vaccine. So by 1990, down to 500,000 people died. And by 2014, it was 73,000. However, globally, rates of disease and death increased from 2017 and 2019 due to a decrease in immunisation. There's also the colossal cost of a pandemic. Look at COVID, the amount of shut businesses and disruption that's caused. It's absolutely enormous. So in the UK, this shouldn't be an issue. We've achieved elimination status before, so basically no measles. The WHO, the World Health Organization's guidelines, is that 95% of the population should be vaccinated. In so-called developed countries like ours, where measles is rare, the recommendation is generally 2 doses. So 1 at 12 months, doesn't work earlier because of an immature immune system, and then a second at around age 4 or 5 to boost immunity. But things have slipped. The rate for 2 MMR jabs in England is way below this, at about 85% for the UK and England. There was a real dip around year 2000, most likely because of a controversy around vaccination and autism, which has since been disproved, so the Wakefield report. Vaccination rates recovered a little bit in 2003 to 2014, but then have generally declined, and we think that's probably due to the impact of COVID and vaccine hesitancy. So this has led to measles cases in England and the need for a new measles elimination strategy called for by NHS England. So what can we as a geospatial service do to help? So NHS England South West asked about MMR data. This ultimately comes in from GP practices, but it's collected by CHIS teams, which is Child Health Information Services. They're local clinical care records for all children in an area, but particularly for public health interventions, especially screening, immunisation, and the 0 to 5 Healthy Child programme. The South West had several CHIS teams, and the South West Public Health teams are the data controllers. So they asked their CHISs for a data set of MMR vaccinations for all children aged 0 to 19 for all 7 ICBs in the South West. We had a sort of discussion about the kind of things we'd done before to support immunisations in the COVID pandemic, and we agreed that it'd be worth them sending us the data and seeing what we could do with it. It was a colossal spreadsheet, hundreds of thousands of children's worth of immunisation records. And by the way, we're always really careful with the PID. We don't ever want to know anything we don't need to see. So we don't want to see, in this instance, names, NHS numbers, anything identifiable. But we did need to know a few things. So we needed to know the vaccination status. Has a child had no 1 or 2 MMR jabs? The age group, ethnic group, and a location. So here's a bit of the real world to describe the location. So every person tends to live in an address, a building where they live, as far as the most recent records are accurate. But we didn't really just want to know about individuals. We wanted to be able to show patterns. We wanted to show some granularity, but we don't need sort of household individual level. And we didn't want to reinvent the wheel. So here the census helped us. So let's zoom out a little bit. And a bit more. And a bit more. Okay, and actually, swap the satellite imaging for a simple map background, because that photography gets a bit confusing. What you can see here are little dividing lines that split the country up, and they're called lower super output areas, or LSOAs, but not losers, as a colleague once called them. Around 1,600 people live in an LSOA. You can see that original house. There's a purple dot and a black dot in the middle. What we wanted to do is aggregate the data up to LSOA, plus the age and ethnicity, then do calculations to tell us which of these people have been vaccinated and which ones haven't. So the LSOAs are really useful. They're the building blocks of many other administrative boundaries, such as local authorities and integrated care board footprints. And also because they're created by Office for National Statistics, publishers of the census, there's usually more data you can combine with them. The census tells us more, things like deprivation. So the NHS has a Core 20 initiative. LSOAs are given an IMD decile, so 1 to 10. 1's the most deprived, 10 is the most affluent, and the Core 20 are 1 and 2, so the 20% most deprived population areas in England. We bring all this together and we create a map. Now, I'd 100% love to show you one of the live dashboards that Ian and I and the team have created, but IG rules are pretty strict, so we can not only just get the minimum data in, but we can also only show it to the people who it's explicitly for, so our NHS England partners and us as analysts. Oh dear, my machine's just turned itself off, so I'm going to have to wing it a little bit. But so I've made a demo app, basically. So this is here on the screen. We don't work in Wales, our team, so I've made up an integrated care board in Wales and made some demo data. So what this shows here is a heat map. So it's the whole of this imaginary ICB split up into LSOAs. A dark colour shows a really low vaccination rate. A light colour shows a higher vaccination rate. And all the while, there are these graphs at the bottom that show you the MMR1 and MMR2 uptake. It's probably too small to see there, but the MMR2 uptake is about 85%, and that's currently the same as the national average in England. So, not good enough, basically. The WHO say it should be 95%. So if you zoom in on an area, so here I've zoomed in on the sort of bit at the bottom, so basically Swansea, this will bring up the individual vaccination rate for a single a single LSOA. You probably can't quite see it, but that's saying it's IMD decile 1. So I picked on a particularly deprived area and showing that the MMR1 rate is 76% and the MMR2 rate is obviously lower because you have to have had jab 1 to have jab 2, about 66%. So significantly lower than either the national average at 85 or the WHO target of 95%. So that's an area that needs some attention, basically. We also can, so what that data was showing was for all ethnic groups, all ages, but you can then sort of delve into the data. So you can slice and dice like you'd be able to on a spreadsheet. So what I've done here is change the filter on the left so that it's for the Asian and Asian British group. That's a very broad group, but we initially can filter the data into broad ethnic groups. And that shows that actually the overall MMR2 uptake rate is closer to 95% there. So that group isn't doing too badly, but it's not the case for all population groups. So advance here. Here I've changed the filter to a group that we call not recorded. And this is basically, sometimes we don't have the data, sometimes I'm not going to tell you, basically. It's a group of people who don't engage very well with the healthcare system. And the Asian group before it's a relatively small number of people, maybe 10,000 out of the 200,000 total population. This is a much bigger population, actually. It's many tens of thousands. And as you can see, the MMR2 uptake rate, it's a little bit silhouetted, but it's only half a moon. It's close to 50%, like really, really low rate. So within this population group, there's a very high risk of measles spreading. If there was a case with a very low uptake rate, it would spread. So this is an area where you need to concentrate. So another way we can aggregate is by primary care network. So primary care networks, as you might know, are basically working groups of GP practices, but our teams developed a way of giving a primary care network a footprint So an actual area of influence where the majority of people within that footprint are registered to a GP practice of that primary care network. So they're really useful little geographic areas. So I think in the next slide I picked PCN 3. I gave them really boring names. Some PCNs have got quite good names. There's one in Surrey Heartlands called WHAM, which sounds pretty cool. And there's another one called Alpha, which sounds pretty assertive. But this is PCN 3 in Hay-on-Wye with its lovely tea rooms. And that's about 87%, so a little bit better than the national average. Another thing we can do is aggregate up to not just to the population areas, but up to GP practice level. So you can see what the vaccination rate is like at GP practice level. And in our live apps, we also aggregate up to schools, so you can see school areas. We show change over time, so you can see the impact of interventions. And we've developed a method of showing catchments of schools. So if we know where the areas that children from school are, you can see what the area of influence for a school is. So if the rate is very low at a school level, you can see the geography where the school children are coming from, which can often be really interesting, particularly for a specialist school, like a religious intake school. I have quite an interesting shaped catchment area, and they can focus in on that. So that's basically what we've been doing. We've been providing these applications for NHS partners in Cheshire and Merseyside, up in the northwest. For the whole of the southwest of England, we've got aspirations to work in the southeast and other areas as well, and also in the Midlands. Feedback's been really good so far. The apps are now sort of live and operational, being refreshed every week. And the idea is that we can do everything we can to get vaccination rates down, reduce the impact of the potential of disease outbreak. And our aspiration is to take it further. So this is currently looking at children's data. We want to look at adults as well. We want to look at other vaccination programs going forward. So that's what we're up to, basically. So according to the time, we've got a couple of minutes. So if anyone has any questions or any have come in, please let me know and I'll do my best to answer them.
Big round of applause for Rich. As you are a discerning crowd, you've decided not to use the Slido. And I'm guessing it's because you want a personal interaction. So that's fine, but we have time for one question. Over to you.
Thank you. I don't know the Slido code, sorry. Have you looked at using this and live measles outbreak data to look at, can you get geo-based data from now UKHSA?
A good question. I've not found it at a particularly granular level. So I found it like at a strategic level, and I've looked at incorporating that at the same time, but I haven't found a particularly granular source for it yet. If there's something available, I'd love to incorporate it, actually, in which case that's a great idea.
If it's a reportable disease, then they have to, if it's like a reportable infection, then they'll have information about it. I just thought it would be interesting if you, when you were talking about schools, if you were to see that you were getting cases in schools which still had high coverage, it might just be because, if it's like, if you were to say 90% is good, there could be that 10% where your outbreak is happening. But yeah.
Cool. No, great idea, I think.
Cool. Thank you very much. We have a quick question from Slido. An interesting one around PCNs in geographical areas. So are PCNs coterminous with their LSOAs? So how do you decide a PCN's geographical area? I need my glasses. Is it a join of all the LSOAs registered to its GPs? So how are you?
I think the answer is yes. So we basically use LSOAs as the building blocks. So they are coterminous. They all sort of nest together. For each LSOA, we look at the population in there, and it might be sort of, 15% to one group of practices in one PCN, 10% to another group of practices in another PCN. And if then the majority, the remainder, sort of 75%, is of another PCN, we will mark that PCN the winner, and that LSOA will become ascribed to that PCN. Then we join all the LSOAs up for whom that's the majority PCN, and that becomes a footprint. So it's quite a simple methodology, but it means you can explain it in a couple of sentences, basically. So it's quite simple, but it's a valuable way of describing PCNs. And there are other ways of doing it, but ours is quite nice and neat. So.
Thank you very much, Rich. Do we have time for one more? Yeah, one more. I saw a hand. 2 seconds.
Just two really quick questions. The first one on what you're saying about the way you've defined PCNs. Would it be possible to just get the registered GP at the patient level data and do it that way so that you don't have to sort of figure it out in post with your different distributions. And then the other question, really quickly, is we did a similar analysis in Birmingham City Council. They're just using the aggregated data at GP and school level, but not all GPs feed into CHIS. I'm not sure if that's also been an issue in your area and how you've overcome it, or if it was particularly, big issue.
Oh, yeah. So the first question was around PCNs and is there another way of doing it based on GP registrations? Our methodology is based on GP registrations. The issue is that particularly in an urban area, there'll be tons of people from one practice and tons of people from another practice. So you've got to come up with a way of just deciding a majority. Otherwise, they all just sit on top of each other. Same as if you just merged all the boundaries for the practices in a PCN. You end up with basically a big spaghetti mess that isn't that much use. So although, there are definitely nuances to how you can look at it, it's a neat way of looking at it where you get to a useful endpoint, basically. And we realise there are limitations. And the second bit of what you asked for, what was that? Sorry? Oh, right. Yeah, no, we're definitely aware that the data quality is different in different areas. So far where we've been working, our own team, SCW, are the CHIS, and the data is complete. But yeah, we're definitely aware that it's not the case everywhere in the country. So, there'll be data battles elsewhere to be fought if we work in other areas. So, yeah, we do know that and acknowledged, yes.